Okay, very briefly, let's kind of discuss a little bit on chapter 10. This is going to be a very short lecture, basically because chapter 10 kind of covers things that most students who have already been through medical insurance processes already have a general idea of. Because it basically talks about coding and reimbursement. And again, if you've had procedural coding, diagnostic coding, medical insurance processes, you already have somewhat of a background into these particular systems that I'm going to mention in chapter 10, but I do want to cover a little bit about the chapter. So let's first start to talk about how healthcare providers and third-party payers, how they collect, store, and process data. They do this by way of what we call nomenclatures and classification systems. So when I say medical nomenclature, we're talking about clinical and medical terms that's used to classify diagnoses and procedures. When I say medical terms, I'm saying things in reference of cardiology, bursitis, appendicitis, hematology, dermatology, those things that are clinically and medically related to whatever the patient's diagnosis or procedure is that they're having done. Another way that they classify or shall I say collect, store, and process data is by way of coding, which is a type of classification system that uses ICD-10, which is what we're on now, CPT and HCPCS codes. Now, the Centers for Medicare and Medicaid Services, pretty much they manage Medicare and Medicaid services through what we call a PPS, a prospective payment system. They have fee schedules and payment systems that are set up for physicians so that they can properly charge patients for the services that they render. Now, with hospitals, they use what you call charge masters, and a lot of physician offices use those as well. Charge masters are used to record encounter data about ambulatory care. And remember from previous classes, ambulatory care is your outpatient care. So ambulatory care and any other services that a patient has done. Charge masters are crucial to the billing process. And when I say crucial, charge masters have to stay up to date. Charge masters are those systems that provide every diagnostic and therapeutic test or procedure that can be performed on a patient. They also include the pricing for each of those systems. So therefore, each of those tests and procedures, therefore, a charge master it is imperative that it stays up to date. You want to always make sure that you're not overcharging or undercharging patients for services that you are rendering to them. Okay, so the next slide talks about some of the different type of nomenclatures in order of development, starting with way back in the 1800s. There's a table in your book, table 10-1, that goes into more details about these nomenclatures. I don't do that in the notes. I ask students to go through their book and look at that chapter or look at that table in chapter 10. It's table 10-1. And again, it just talks about what nomenclatures were like beginning back in the 1800s, all the way down to where we're at now currently with how we do coding and reimbursement. So in your book, in table 10-2, it talks about the medical classification and coding systems, and it starts with the London Bills of Mortality, and it goes all the way down and brings us up to date to where we are now currently with the way we do billing and coding. So now currently the terms that you're used to hearing now are CPT, ACPC, like ACPS, ACPHS, HCPCS. You're used to hearing ICD-9 or ICD-10. That's what we refer to our coding and reimbursement systems now versus what they used to be classified in years ago. The UMLS, Unified Medical Language System, basically it helps or assists health professionals and researchers with integrating any type of biomedical information from different sources. So this is in reference to biomedical research that is conducted on a lot of patients. You know, you have a lot of facilities that do what we call clinical trials, test trials, and that involves a lot of biomedical research. Now, as one of the slides in here, the medical classification and coding system, the London Bills of Mortality, that is actually the very first classification system. Now, with that system, it's a little bit different than kind of what we're doing now. Back then, bills were collected and were collected by what they call parish clerks. These clerks did not have any kind of medical training. Their job was pretty much to collect billing or bills for services that were rendered back to patients way back when. Now we've got a little bit more fancier now with a lot of the way we do billing. We've got a lot more fancier because now you have situations where you have things going through third-party payers. Now you do still have your patients that are private payers. So you know these are the people that pay directly out of pocket. You charge the services directly to them. But when I talk about third-party payers, mainly what I'm referring to is insurance companies. Insurance companies play a vital role in services being reimbursed to physicians and also in payouts from a patient's insurance to the doctor for the services that they render. So third-party payers, for them, it's important that coding is done in a very timely manner, in a very efficient manner, in a very precise manner, because again, doctors' reimbursements are relied upon that. So just think if we didn't have a definitive coding system, or we didn't have a just think of a reimbursement system never existed. In today's world, how would the physicians get paid for the services that they render? Okay. There are several different types of manuals that are used for coding systems. You have one that is for just routine medical procedures. You have one that is for mental disorders, that classifies mental disorders. We call that the DSM. You also have one that has to do with dental procedures as well, and we call that the CDT. That's the current dental terminology manual. You also have what you call the CPT. That's the current procedural terminology manual. That's the one that classifies procedures and services. Okay. You also have a manual called the ICIDH. That is the one that's for classification of injuries, disabilities, and handicaps. You have the HCPCS, the HCPCS. Those are your level 2 national codes. This is the coding system that classifies medical equipment, injections and drugs, transportation services, and any other services that are not already classified in the CPT, the current procedure terminology manual. And of course, I've already mentioned about the CDT, classifies dental procedures and services. Then you have your NDC. This is your National Drug Code manual. That manual is managed by the FDA. Okay, so we know that's the Food and Drug Administration. Then when I mentioned a few minutes ago about third-party payers, I put a slide in here so that you can see what I meant when I was talking about third-party payers. There's a table in your book, Table 10-3, that talks about these different payers in full detail. I don't cover that on the slide. I give you the list, and so I'm asking you to make sure you go back to Table 10-3 and read about each one of those individually, just so you can have a background on the purpose that they serve within the coding and the reimbursement systems. Then we move on to different types of methodologies in which services are reimbursed. So in table 10.4, you have a listing of prospective payment systems, and these are categorized according to the year they were implemented. Again, I have a list up here, but there's full details in your book in table 10-4. Be sure that you go through there and read about each one of them so that you can get a general background on each one. That it also includes the long-term care diagnostics related groups, or DRGs, and then you also have one for end-stage renal disease, a payment system associated with that as well. And then lastly, what I want to mention is some of the things that, how can I say, are some of the things that are used in coding and reimbursement issues that you different types of forms that are used, but then also issues associated with coding and reimbursement. So let me first begin by talking about charge masters and encounter forms. I made mention of that a little bit a few minutes ago about the charge masters, and when you see charge masters, I always know that you need to relate that to encounter forms. Encounter forms are the forms that are used for doctors to record patients' diagnosis, tests and procedures that were done, injections that were given. Always relate those two together. When you hear the word charge master, just mean this is a document that lists all of the procedures, services, and supplies provided to patients by a hospital. Okay, charges for each one of those also appear. When you hear the word encounter form or super bill, it lists procedure, services, and supplies provided to patients by a physician. So charge masters are what's used in hospitals. In doctors' offices, we call it the encounter form or the super bill. Both of them pretty much does the same thing. Okay, so if a doctor marks something in charge master for, like, say for instance, if he marked a blood count in the charge master and it carries a charge of $15 or whatever, it has a CPT code assigned to it. Same thing if that patient went to the physician's office and on the form there was a blood count circle, had a CPT code to go with it, had a charge associated with it. It's the very same thing. The difference is the type of facility in which either one of them are being used. You hear a lot about the UB04 or the CMS 1450 and the CMS 1500. So we know that the CMS 1450, basically that's a form that is submitted by hospitals, skilled nursing facilities, and other institutional-based providers to payers to help with reimbursement for healthcare services. Whereas the CMS 1500 is the universal form that's developed by CMS and is used by providers of services such as physicians. So you see the UB04 more in hospital settings versus the CMS 1500. You see that more in physician office settings. EDI, electronic data interchange, anytime. Basically what I want to say about that, that's just computer to computer transfer of patient data. Anytime that happens, you got to know that you always have to make sure that you continue to follow the HIPAA regulations and rules associated with that. And lastly, fraud and abuse. The definition of the two. So fraud is an act that represents a crime against payers or other healthcare programs. Abuse is a pattern of practice that is inconsistent with sound business, fiscal, or health service practices. So fraud is pretty much the act that you perform against whatever the insurance company is. So let's say, for instance, Medicare. Abuse is willingly and knowingly knowing that you're doing things. Let's say, for instance, you're overcharging patients and you realize it, and you're doing it because you're trying to increase your revenue within the facility. Either way, in the book, it talks about some of the different types of frauds and abuse that can happen within healthcare settings. So make sure in your book on page 338 you look at that list, because it gives you 3 or 4 different types of examples so that you can get a better understanding of if you see this or hear of this, you know that that's an example of fraud. Or if you see or hear this, you know that's an example of abuse. So that's pretty much it for chapter 10. It was really short, sweet, to the point. Always make sure that you go back and read chapter 10. And also know that there is a set of PowerPoint notes that is associated with chapter 10 in Doc Sharon. Again, the notes just serve as a highlighted piece. The book gives you more in-depth knowledge of the different things that is listed in the PowerPoint. Thank you.